Health Initiative is a nonprofit. We're about to celebrate our 20th anniversary, and we convene executives who are transforming healthcare through technology and innovation. Folks like Dr. Lichtenfeld, who figure out how to use innovation and technology to transform care for cancer patients, and other esteemed folks. So we would be delighted to have you join our organization. This is just a sampling of folks that are involved with our organization right now. If you don't see your company's name up there, it should be up there. So please reach out to myself or Claudia. You can reach out to us through the chat box, and we will tell you how to get involved so you can be up here like Dr. Lichtenfeld is. Next slide. We're focused on all different types of areas: transparency, interoperability, privacy, and analytics, really all the key areas about getting people and technology to connect and getting information to the right place. Next slide. But right now, we're focused on how all of those areas come together around COVID-19. And we've been spending a lot of time on educational programs, executive insight programs, interviews, papers, and pushing out resources around COVID-19 and how the healthcare industry can better deal with this pandemic right now. We've got a couple of great programs coming up. Next week, we have a really superior webinar on contact tracing and patient matching. This is going to be a really neat one, so I encourage you to sign up for that one. We've got one coming up on June 1st around how COVID-19 is influencing consumer health behavior. I think we all know our behaviors changed quite a bit over the last 8 weeks, so that should be interesting to discuss as well. And then June 11th, after the curve flattens, what's next for healthcare and COVID-19? I hope we all just see the curve flatten. Particularly here on the East Coast, we're looking forward to that. But talking about what's going to happen next and how this is going to impact us. So please sign up for those programs. If there's another program that you want to see up there, or if you'd like to see the programs that you've missed, we've had about a dozen so far, go ahead to our website, ehighDC.org, or you can reach out to Amy at ehighDC.org, and she'd love to talk to you if there's something you'd like to present on or talk to us about. Next slide. And that's it. So Len, welcome. We're happy to have you here. So
glad to join you.
I mean, one of the things I've been dying to talk to you about, Len, is we've been spending so much time talking about COVID-19 patients and patients who are dealing with coronavirus, and we haven't spent a lot of time talking about patients who have other conditions and how this is really impacting them. And that's why I think it's so important to have you here today and really share with us what's happening. Can you just kind of give us a general sense of what life looks like for someone who's being treated right now?
Well, thanks, Jen. And it really is a pleasure to be with you and be around so many friends, because EHI has been so much a part of my life and given me perspective and engagement in the health technology sector. So I thank you for everything that you all have done and that Claudia and colleagues have done to make this organization the special one that it is. So when we talk about cancer, I mean, and again, given limited time, let me just try to truncate a little bit, if I may. It's had a huge impact on cancer care. We noted right at the very beginning. So for example, the American Cancer Society came out pretty quickly. And we said routine cancer screenings should not be done. And now here we are 2.5 months later, and we're starting to open up, and people are talking about the impact, the substantial decline, by the way, that did occur in cancer screenings, opening up. But what's the impact going to be on outcomes for those with, those with cancer, but more importantly, those who don't know they have cancer and are at average risk and now need to be screened? And what's going to evolve, as we have the unpent demand, that needs to be dealt with, and who gets the priorities going forward. So that's one piece. The other piece was cancer care in general just really had difficulty. There was an immediate switch, interestingly, to virtual visits. I mean, that happened almost right away in many major centers. But we start talking about the seriousness of COVID-19, the redirection of resources within medical facilities and hospitals, obviously in particular, slowing down who could come in the hospital, who really needed to be in the hospital, changing treatment programs, delayed diagnoses. There were all sorts of things that happened in many locations. So the impact has been huge. We know from our research that we've done at the American Cancer Society that impact is real in other circumstances, and we have no doubt that there's going to be impact with COVID-19. Hopefully it won't be much, but over the next literally days, weeks, and months, our epidemiologists and many others are going to be studying what has actually happened. And unfortunately, and the good news is people came together. You know, we're having a webinar today, but the use of webinars, as we all know, increased dramatically, and experts were able to come together and discuss what could be changed safely, or how the treatment programs could be rearranged, and what really needed to be done and what didn't have to be done. So we're in not the perfect place, but not as bad a place as we could have been. And now we have to figure out what's the best way to open up, to move forward, and get back on track to the degree we possibly can.
So we always get questions, I think one of the biggest questions is, what about the patient who's getting chemo in a hospital? So, what are kind of are there different ways that medication or treatments are being administered now, or were those patients kind of put at risk and sent to the hospital anyway? Kind of what was that thought process, and how does that work for patients and doctors?
Well, it was, to be honest with you, sometimes it was very ad hoc. So there are different situations. There are patients who really must have immediate treatment. A patient with an advancing lymphoma, a patient with acute leukemia, a patient receiving a transplant, a patient receiving CAR T therapy. Those patients went to the top of the line, and everything possible was done. Some circumstances, treatments could be changed from perhaps an intravenous treatment to an oral treatment, because the desire was, and to some degree still remains, to keep people out of facilities. And then for patients that had to come in for chemotherapy, we've done surveys, and we found a number of people who responded said, my treatment's been delayed. And for some patients, it never started. Unfortunately, in circumstances where perhaps there's a third, fourth, or fifth line of treatment, in what might be, and I don't mean to be trite, but a Hail Mary, a family says, can't we try one more thing? Maybe some of those treatments weren't done. And we actually got reported in clinical trials, new investigative therapies. Some of the trials never started. Now, workarounds, those are in progress. Pharmaceutical companies and research centers. But we know, for example, in research, a lot of the clinical researchers had their research, they couldn't do it anymore because they were moved over to COVID-19 care. And in the laboratory, which people don't even think about much, but basic research, we did surveys, half the basic lab researchers couldn't get into the labs, and the other half could only go in a limited schedule. And so, yeah, workarounds are happening. And there were people who called us and said, I can't get my treatment, I can't get my surgery, I can't get this. On the other hand, there's another group of patients who perhaps, the example that I use is early stage non-invasive breast cancer that's not aggressive, that's small. Perhaps starting anti-hormone therapy would be okay, and surgery can be delayed, because there's actually some evidence to suggest that's all right. So a lot of it was ad hoc. More of it's becoming consistent because more conversations, more groups have come together with guidelines and recommendations. And we're in a better place today, and centers are opening up and trying to do everything they can to keep people safe. Maybe not as many tests as we used to have. Now it's the healthcare you need, not the healthcare you want. And those are some of the adjustments that have been made along the way.
So did the American Cancer Society or ASCO, they did come out with guidelines to help clinicians make some of these decisions during this time period?
Well, actually, we don't make treatment decisions. We do treatment guidelines, and we do take phone calls and help advise people. But what was interesting, the professional society. So, for example, in breast cancer, ASCO, the National Comprehensive Cancer Network, the American Society of Breast Surgeons, the American College of Radiology, the radiation oncologists, and perhaps others, they actually came together and put out a position paper on what was urgent therapy, what was not urgent therapy, what was emergency therapy, and what could safely be done. And I assure you, they've had plenty of webinars to talk to clinicians around the country. So there has been some standardization. The GI folks have come together and talked about colonoscopy during the time of the pandemic, and what can be done safely, and what recommendations are in place, or whether or not doing a stool test at home might be an option this year. So, and the cancer side, I've done a fair number of interviews during the course of this time to share information. And one of the other examples is maybe mammography. Some women want to get a mammogram every year. They're people at average risk, not people who are at high risk, not people who have symptoms, or they have breast lump whole different story. That needs to be taken care of. But for example, a mammogram maybe can be done every other year instead of every year. That's a recommendation, by the way. So
Right.
there's no need in certain circumstances to do a test all the time. Maybe you have other options, and we tried to share that with the public.
Yeah. So you mentioned you've gotten a lot of feedback. Have you guys collected any actual data or any research you can share with us yet in terms of the impact this has had?
I don't actually have those papers handy here, and the numbers, I never like to talk about numbers unless I'm looking at them, so bear with me. But yes, we have our sister advocacy affiliate, the American Cancer Society Cancer Action Network, had done an initial survey and now has another one that's wrapping up as we speak. But that initial survey, we found a lot of patients, 50% of the patients said that they had treatment delays of some kind. A number of patients, treatment, they were concerned about treatment, and something that's not necessarily a technology issue, but people are worried about how they're going to afford their treatment. There's been a tremendous amount of job loss, and that was reflected in our surveys as well. On the research side, I've already talked about the fact that researchers couldn't get access. Their clinical research was interrupted. Their basic lab research was interrupted. Their funding has been interrupted, and with all the, we're dealing at a very high population level, and as we go through this pandemic, we'll learn the layers will be pulled back. But we have basic researchers who've had to stop their work. Have they lost their work? In some cases, yes. How are they going to rebuild? How are they going to be funded? Because funding, we've had postdocs, young, bright investigators who have been told, you can't continue. We don't have the funding, it's run out, and how that funding is adjusted over time. We're hopeful that there will be resources. We're a charitable organization. We depend on donations. Our donations have gone down substantially, and how's that going to impact our ability to fund new, innovative investigators going forward? A lot of unanswered questions, and we're like everyone else, we want to get out of this. I am to be involved in planning for an organization, and I don't suspect it's going to happen anytime soon. So how are we going to be able to meet the needs of those we serve, our patients and our research community and our own internal research community? In addition, there are a lot of papers right now. The research we see and what's the impact. There are articles coming out, but they're real high-level stuff. I mean, they're medical, and this isn't being negative, but a medical record company putting out a white paper is not a peer-reviewed research paper. Right. But that's what we've got to deal with, and that's where we all are right now. We're all trying to get that interview information, but we really need high-quality information that's research-based, so we can really say to people, this is what actually happened. We've done that kind of research before. We at the American Cancer Society will do it again, but right now we've got to use what we've got, and databases that our listeners are familiar with, are very, very helpful at this particular time.
One of the things you alluded to before was around the virtual care that's happening now. And I know on our other webinars, we've had a lot of discussion with clinicians about how that's impacted payment. Can you talk a little bit about how that's impacted your field and the clinicians and what lies ahead?
Well, I can talk not only from broad experience, but also my wife happens to be a gynecologist and at Emory University here in Atlanta, and they went completely virtual. Their general GYN clinics, for example, closed down. Cancer programs were very quick, and I think, I say surprisingly, but they hadn't done a lot of virtual care before. Well, they moved into virtual care very quickly. However, as you might anticipate, there's a lot of cancer care that is hands-on. You have to have x-rays or scans. You need to have treatments. You need to have physical examinations to see what's happening to a person at a point in time. So there was a balance, but the initial response was to get as many people out of the clinic as possible. And I think that's one of the, as many folks on this discussion are aware, I think that's going to be one of the real things that will stick. Now, it won't be as much virtual as in some areas as others, but it's going to be an impact. But you can't get a virtual blood test, and you can't get a virtual X-ray, and working around those issues is a major concern for those who treat patients with cancer, and they're doing okay. They're making those things happen, but they're not as quick. Coming out of this, it's going to be interesting because, you know, with the need to make sure the equipment's disinfected, to keep patients apart, and to help protect health workers, and realizing resources will be diverted. We're not going to have the capacity we have. We may have longer hours, we may have weekend hours. Some people will say, hey, hooray for that. But there will be tools, and there will be adaptations that occur. You know, I was on an EHI call last week and talking about technology, and I believe it was the Mayo Clinic was talking about the blood pressure cuff and the virtual stethoscope. And I have to tell you, I used to talk about that 20 years ago. And I said, one day we will sit in we won't have to go see the doctor in the office. We'll sit at our desk and they'll be able to do my general exam with blood pressure and listen to my heart. I can't tell you that people thought that I belonged somewhere else. They said, yeah, it never happened. And here we were last week at EHI talking about just that capacity. It's here now. So I'm excited. I'm excited. I'm excited from a lot of reasons. Better use of resources, better use of everybody's time. Payment, that's going to be the hooker. And I'm sorry to go on so long, but no, I'll tell you, I'll share with you a little thing that doesn't get much attention. First off, those of you out there who are in the technology arena are always wondering, how do we get paid? I sat on the committee that helped determine the payments for Medicare services for 24 years. My wife was on that same committee. She turned to me the other day and she said, and we know the ins and outs of what happens. And I'm going to make a prediction here that when this all calms down, CMS, which is responsible for the Medicare fee schedule, is going to take a real careful look at the inputs for virtual care on what we call evaluation management services. And unfortunately, they may say, you know, it doesn't take as many services behind the scenes, office expense, things like that, to do a virtual visit. And the risk is that will be cut. So stay tuned. You heard it here first, but it may happen. And then the second part that always has me concerned is, how are we going to pay for all in some cases, not every, but some cases, really terrific virtual services that we can do? Because it's one thing to talk about it, and you may have heard me say this before, it's another thing to get it paid. Yeah. And when it gets paid, it goes through a committee that traditionally hasn't valued the physician services as highly as it does a surgery, for example. So that's a whole topic for another day. Yeah. But it's going. I think that will loom larger, and how much of a barrier will it be? So if something's done technologically that makes it more efficient, yeah, and reduces the cost elsewhere for an organization, terrific. But if it involves, you know, some of the more things like a doctor speaking to a patient, somebody may step up and say, it doesn't take as many nurses and office space and other things to get that done. So yeah. Stay tuned.
And we know right now they are paying, or they say they are paying at the same level as an in-person visit. So
yes.
Yeah. So for folks, So for folks who are aware of that, I mean, this is the time we are trying to promote and encourage CMS to adopt those items permanently.
I assure you, a lot of people are in your camp. I mean, you get a lot of support. Everybody, a lot of people are not only concerned about, but they're enthusiastic about it. And CMS loosening the regulations, increasing the opportunity to use various venues for virtual visits, that's been huge. And I, for one, hope that we're able to see it for what it is and move forward in a very positive way, because it makes a big difference for so many people.
One thing I've been wondering about, Len, and I saw that in Germany and some other places, they're doing more home visits. So they have like a team of clinicians that is going to people's homes for those items you mentioned, you know, the blood draw and those things that you can't do, and you really need a clinician. Are we seeing that anywhere here? Or is there a reason that we're not adopting that and other countries are?
Well, I don't know how many hours you have to talk about the American medical system and what it adopts and what it doesn't adopt, and what incentivizes it to adopt whatever it does adopt. So as you move to value-based care, you're going to see a lot more people thinking a lot more intelligently about what we need to do and how we need to do it. one of the things that's floating around Washington now is, increasing payments or opportunities for home-based chemotherapy.
Yeah.
Understanding from my perspective, and I have to admit neutrality because I haven't looked very carefully at it. Okay, so it's not, I don't like to make great comments, but there certainly are some treatments and some things that can be done at home. So for example, I got a media inquiry from a reporter who was all excited about the fact that a cancer clinic in somewhere, I think it was in Wisconsin or Minnesota, had set up a tent outside for drive-through treatments, things that could be done for patients they wouldn't have to come in the office. Well, based on your question, that could be done at home and probably at a much lower expense, or maybe they ought to keep that drive-through open like the bank. It's I actually heard of one practice that has took over an old bank building and they have a drive-through window. And during COVID, they've been doing things as general medical practice, but they've been doing things through the window, right? So, pandemic has been terrible. And again, there's nothing to be happy about having this pandemic. It's changed our lives and unfortunately ended the lives of too many of our family, friends, and people we know. But in a very difficult situation, there are beneficial consequences. And it gives you the opportunity. There's been some really innovative thinking about what we do. And medicine's not going to be any different, nor should it be any different. And in value-based care, let's think differently, because people are applying those principles. Leaders are applying those principles. For again, an example, but it's not medical. The American Cancer Society has offices around the country. And we've had those offices for a long time, and people are used to working in offices. And suddenly, I happen to be leading the pandemic effort at the society in a number of arenas. Suddenly, we made the decision we wanted everybody working from home, and we did it in early March, actually. And do we have enough computers, enough technology, enough bandwidth, all those things that everybody's familiar with? Guess what? We moved. We decided we're in a digital first world. Work from home. We're not reopening. We're letting go of a number of our offices. We're reducing our footprint as we speak. Well, if we can do it, so can medicine. And as value-based care takes a role and gets more and more firmly in place, I would bet on new innovations and new ways of doing it, whether it's home-based treatments or other ways of getting the information. Of course, technology playing a huge role in that as we continue to evolve in that sphere as well.
You kind of hinted at that before, because it may not take as much, it's more efficient sometimes to do a virtual visit, and it may not take as much back office support to do a virtual visit. Can you talk a little bit about what other types of innovation have you seen? Some of those neat things that you've seen, ways that technology and innovation are being used now. You mentioned the stethoscope, and give us some,
Oh, I'll tell you the one that's front of mind. Yeah, I'll tell you front of mind. Okay. And those of you who know me know that I should have been born in Missouri. I'm a show me kind of person. You can't just, and I don't care. It's not just information technology or the technology we talk about. It has to do with laboratory tests, a number of other things. Everybody's out there. A lot of people out there willing to tell you how great their thing is, but it really needs to make a difference in care, increase value in care, make care better or easier to deliver. Technology in any sphere for technology's sake is not, to me, necessarily terrific. I mean, it's terrific, but it's not, it has to make a difference. So here we are on the phone call, a webinar last week at EHI, and I'm going to give a shout out, and the person I give a shout out to probably is going to say, really? But Drew Schiller from Validic, he presented the tool, and the tool was an app, and I assume the device-based app where people can take their temperature and report their symptoms, and it goes into a chart, and it can be collated at a central location. I have Hope Lodges around the country. We've had to close them down. Those are places, there are about 34 of them now that are open, and 2 more coming online when we get back.
Yeah.
Yeah, right. So that patients can go to Hope Lodge and stay for free from a distance and get their treatments at nationally recognized cancer centers. Mayo Clinic comes to mind as one example, both in Jacksonville, Scottsdale, and Rochester. But there are others all throughout the country. And we provide a free place for cancer patients to stay. And so it's really important. Now, we had to close those lodges down. Our patients are a highly immunocompromised population at high risk. We are not a nursing or medical facility. We're not a nursing home. And if we had COVID get into one of those lodges, we would have been in the same circumstance, if not worse, than some of the nursing homes. So we had to make a difficult decision. And by the way, we turned those over to our partners, our hospital partners, so medical staff could stay there who needed a respite or didn't want to go home. So we're moving out of that now, but we wanted to have a public service, and that was well received in many communities.
Yeah.
But I got to reopen those Hope Lodges. And I got 1,500, not me, but the Cancer Society has 1,500 peak guests and plus employees and plus volunteers who tend to be older. They're in those lodges, and we need to make sure they're okay. Wow, would I love to have that device in that arena for people to validate every day in a record that's uniform and effective and accurate, to tell me that their temperature is X and that they're okay and that they can be in the lodge, as opposed to check off the box and keep it in a file somewhere. That's an example. I have to say, that's an example of technology that I think is not only going to make a difference for healthcare, but can make a difference for a lot of organizations that are facing the same dilemma that I'm talking about. And plus, of course, I also have employees, I have volunteers, I've got events, and I've got to figure out, and when I say I have a great team of people working with me. I mean, all through the organization, and teams of people. Really, it's fascinating to watch the innovation that comes from their thinking and the problem solving. It's been a wonderful experience. So I'm only a representative of that larger group. But think about putting on, we have events that are fundraisers that are critical to our organization. What can we do to make sure that people are safe walking in the door of the, before they come in? So technology has a lot of places in COVID-19 care and COVID-19 business, and making sure that environments are safe. And that's just one example. It comes to mind because it really, as soon as I saw that, it struck me. I said, got it. It's like being able to get a test. What's the best way for us to get people tested? Not a topic for today, for virus or antibody, whatever it may be. So there's an EHI related. I've listened to Drew for years, and I've heard a great presentation on diabetes from him recently. And the one that from last week, I really had an impact. So this place matters, and the work that's done matters.
So talk a little bit about, the risks that these patients are at, or people, not just patients, but people are at right now. Are these, and how long are they going to be at risk? Because I know we're all talking about opening up and getting out there in the world. Should these people be staying home? Should these people be tested? How regular should they be tested? If that, what's your thought on that?
Another 4-hour question. So I'm glad we only have a couple of minutes. That's been part of my existence now for the past number of months. And quite honestly, I'm going to share with you, without getting into detail, nothing has happened that was not predicted or predictable. And nothing will, and we have our own set, thinking going forward. One of the major issues, of course, is how do you determine whether it's safe to open up? I happen to live in Georgia. I don't think I need to share with everybody that Georgia certainly has gotten a lot of attention from what our governor has said and done. I don't want to say more than that, but I watch a lot of data across the country, to get an idea of patterns and behaviors of disease. And we actually spotted some things. I have to tell you, if I may, it may not be directly responsive. One of the things that I did do very early, and they asked me to lead the society's response in end of February. And I immediately turned, I have a colleague, her name's Leora Sahar. And I turned to Leora. She's a GIS person, but I call it geospatial analytics. you know, those maps and things. I turned to Leora, the first call I made, and I said, I need a map. And we put a map together, and we multi-layered that map. And we put together the case incidents, the deaths, by case, by county. We put together where our people live, literally where they live, each person in our organization. We put to our offices, we put our Hope Lodges, we put the occupancies. We had all sorts of layers on there. We had the Hopkins data early on. So we could see what was happening. We actually could see what was happening. And to this day, we still can see what's happening, although data sources are a bit different. But we knew where our people were traveling. And when they were going to Seattle, Washington, we intervened and said, you're not going to Seattle, Washington. And we knew exactly who it was. And when the problems in New Rochelle, New York showed up, we don't have an office in New Rochelle, but we saw an office in Fairfield, Connecticut, and we saw an office in New York City, and we knew the people who lived in New Rochelle, New York. We said, well, you're quarantining at home. We can't have you go into the office. So technology and that data, that geospatial data made and continues to make a huge difference in our planning. Talking to people quarantining cancer patients, the data is still very early stage. It isn't for everybody. I mean, you can't manufacture data and you can't manufacture speed. I mean, you try to get it as quickly as you can. Cancer patients in China were hugely impacted. So death rates were 4 times greater for patients in the hospital with COVID-19. Patients who were in the hospital with cancer with something else had something like a 10 times greater risk of ending up on ventilators. We know that we know cancer patients are immunosuppressed. What we don't know is how long that may last. And in China, it looked like it lasted for 3 years, the impact of cancer treatment. And different treatments mean different things for different patients. So here's the bottom line. Cancer patients, from our perspective and my perspective personally, are at much greater risk of the adverse consequences of COVID-19. And they must be careful. You know, you have to know what's going on in your community. One data source I rely on is the New York Times data, which has been excellent, hugely helpful. But there are other sources. I also look at the IHME data regularly. Although the problem with the IHME data was they actually could tell us when they had what they call a containment date, when it was safe to go back out. And all the states have opened up well before that containment date would have occurred. The containment date has gone away because technology shows us from the cell phone data that people are back to their habits. Georgia went down 50% in traffic. It's now 25%, 50% back of where it was in the beginning. I just watch the data every day and hope I don't see big red markers on the Times data. So patients with cancer, families with cancer who can help their parents, you know, who patients are generally skew older, they really need to be especially careful at a time like this.
Should they all be tested? Should they
all? Good question. You know, and I think if you watch a lot of media, you've seen some of the comments that have been made. And I think one of them is you need to have wise testing. So I don't think everybody needs to be tested all the time. Okay. I will tell you, I do think that patients with cancer going in for treatment into a cancer center need to have or should have periodic testing, but I'm also flexible on that point. But I know cancer centers that were opening up, and some were testing patients as they walk in and are testing patients as they come in for their first visit and perhaps periodically. And I know others that are not doing that. So in our Hope Lodge, yeah, I think our patients and I do believe our caregivers probably should be tested walking in. But test is a moment in time. I'll tell you where I think the real problem is going to be in general. And that's going to be situations in our offices, those that do open up. The same thing we ran into at the beginning. Somebody comes in, you know, my partner, my person I live with in my apartment, somebody I have regular contact with, they've got COVID-19. What do I do? Well, okay, that person, you know, you want to get them out of the office and you want to get them tested. And you want the testing to be done properly, as quickly as possible, but not the rapid test. And you want 24 to 48 hour turnaround so you can get that person back in the office. But what do you do about all the other people in the office?
Right.
So if you get a person in the office with COVID-19, you're going to be getting a lot of people out of your office quickly. The yo-yo effect, I call it. And you need to have convenient, readily available reportable, accurate, underline, accurate testing available in order to manage that. And a lot of it will still be ad hoc. You need people to help you figure out what the best thing to do for each circumstance. I have somebody on the 30th floor who has COVID-19. I'm not concerned about the person on the 19th floor, but I am concerned about the person on the 30th floor. I'm concerned about who their direct, I call them the first cousins. Who's their first cousin and who's their second cousin, who's their third cousin? Not really, but you understand what I'm saying.
Yeah.
And then how that works out. So we're going to go through a lot of learning. It won't be one and done, folks. And antibody testing, as you may have heard, is, I wouldn't be relying on antibody testing right now. Let's put it that way.
Well, so what's been done, you know, I guess we all kind of assume in the healthcare industry there is going to be a second wave.
Yep.
Most likely.
Mm-hmm.
So what can we do differently next time to support cancer patients?
Well, we're going to do the same thing we did the first time.
No, don't say that.
Well, I'll tell you what will be different. I have a little thing, I hope this isn't offensive to anybody. I call him COVID Charlie. And because I want to be equal, I call it COVID Charlene. So whichever one you want to be. Assume that everybody you come in contact with is COVID Charlie. Think like that. And if you think like that, you'll put behaviors in place and strategies in place that make a difference. And the same thing is true for patients with cancer. So, you know, if we get an outbreak in Atlanta, Georgia, which is a possibility, and it may not be in the fall, it may be sooner than that, given what we see going on here in Georgia, we will go back to virtual visits. We will have our operating rooms closed down. We will have our hospitals rediverted. So yeah, that we'll be back in the soup, unfortunately, but we'll have a much better sense of getting those plans in place earlier and what we need to do earlier. You will have been through the drill. We've been through the drill. We've made decisions. So the disruptions will still exist, but they may be less so. When you plan in your location, I literally am making people, we have an office in Atlanta, and I'm making people literally walk through every step they have in that office to think, where's the contact point? And what do we do to mitigate that? If we can, if we get the supplies to mitigate it. So patients with cancer, their care teams, here's something that does concern me. I'm aware of care teams, cancer and other non-cancer, that have done really great jobs of taking that to heart and thinking everything through. And I've had other situations where patients have called us and said, how can I go to my doctor's office? I happen to be an oncologist office when the waiting room is filled with people. That's a danger sign. And I had an internal medicine practice that I used to go to reach out to me and say, come on in, we're open for business, and no problem. No, that became a national item on my list, like I'm sharing with you now. So we still have people who don't do it appropriately, but cancer patients, yeah, I think the cancer care community has really come together. The guidelines are there. Standards will emerge, are evolving as we speak. And I think we'll be in a better place, but disruptions, yeah, we will go back to disruptions if our communities have to close down again.
You know, we got a great question from one of the attendees today about what else can we do to let our patients know that their treatment's still a priority? I think everybody's been told you need to over communicate, and
yeah, well,
what else can clinicians and staff do?
I'm holding back from saying, am I talking too much on TV? I don't know. I don't think so. I'm always open for more invitations, but I talk a lot, as we all know. You know, I'll tell you something that came up really early in this whole process, right in the beginning. And I said this again in a lot of interviews, and I've said it in a lot of places. And I've also said as a core principle of how we at the Cancer Society responded internally with our own folks. Open lines of communication, both ways, that are readily available are critical to letting people know you care, and are critical to having people understand this is a difficult time, but we're in it together. So I believe more than almost anything else is the opportunity, and this is cancer, I don't care what we're talking about, making sure that you as a patient and consumer have a line to your healthcare professional, and your healthcare professional reaches out to you. And now it may be by email, it may be by phone, it may be, no, we can't do an appointment, but we've got it here, and you follow up, and you making sure that can happen. It's always tough to talk to a doctor's office. Now we have to make it much easier to make those communications happen. It may be done virtually through all the tools we talked about. Yeah. I think that's just such a bedrock principle of how you let people know you care. I have to say, cancer patients, they face a lot of difficulties. It's difficult. We all know people in our family, our friends. They can be a pretty resilient group of people, and they're worried about their lives. But taking the time to explain, but they're also realists. And nobody wants to hear, believe me, no health professional wants to call somebody and says, we have to delay your treatment. One situation I was involved in with a surgeon had to drop out of a surgery on a Friday night. The surgery was going to be done on Monday because the surgeon got COVID-19. Of course, the family was panicked, and eventually it worked out okay. No easy answer for that one, by the way. But for the most part, I got to tell you, communication is just so important to let people in a time of crisis. One of the outstanding lessons of this crisis, unfortunately, is that we've had such communications dissonance in this country. Yeah. It is difficult. And I, as someone who's planning, I, as someone who's trying to advise and make decisions, and I, as someone who watches TV like every one of us, my golly, it's been awful. I'm sorry to say that, but it's been awful. And trying to get the types of information we need as accurately, as directly. So we as what we see as a nation also counts so much in our everyday healthcare and making people feel that somebody there cares. I'm worried about this. What do I do? The other piece that's going to be important is communicating about risk, because people are afraid to come out of their homes, or afraid to go to a doctor's office or go to a hospital. My golly, it's not only cancer, it's heart disease, stroke, and other conditions. The admissions are way, way down. And those people didn't suddenly go away. They suddenly didn't stop having a heart attack. We're going to, the fallout from that, we have some data on excess deaths. We need to let people know that we need, number one, let them know the environment's safe in their community. We need to let them know that their doctor's office is safe and that they're doing what needs to be done. And we need to gently hold their hands. A lot of these are older folks. Literally hold their hands to let them know it's okay, and we're doing everything we can, and demonstrate it. Not just say it, but demonstrate that you're doing things. It may be as simple and maybe as complicated as that.
Well, on that note, I want to thank you for being with us today. This has been a fantastic discussion. You've gone through every question that we had asked today, and I'm just delighted that you were here with us. Really appreciate your time today.
It's a real pleasure, and I'm thrilled to be here. I'm thrilled to be part of EHI and the work that everyone is doing at EHI, and all of the member organizations at EHI. What a great job! What a wonderful time for opportunity to talk. And there are people out there doing technology. There are people out there who are doing data. We've had those conversations even on one-on-one bases. What a great time to be able to stand up and show value and show relevance at a time like this. I think the opportunities are frankly limitless to show how much we can do to help things come back to a more reasonable state of affairs. So my heart goes out to everybody. My thanks goes out to everybody. And I appreciate you, Jen, for giving me this opportunity.
Well, we appreciate you, and you've done such incredible work on behalf of cancer patients. So thank you.
Thank you.
All right, everybody. We will see you next week. Thank you for joining us today. Have a great afternoon, and please stay healthy and safe.